Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical PDF for internal medicine, now into the endocrinology section. So I'm going out of order because I'm going based off the topics that are assigned to me as part of my curriculum. In terms of topics, of course. They're not assigning the PDF, but I'm using this PDF to understand the topics, of course. So that's why I'm using this one in this particular order, of course. You can follow along as you please in terms of whatever order you find the most sensible for your particular context and consideration. Anyways, let's get into it. Internal medicine, endocrine. Vasopressin conditions. Vasopressin, aka antidiuretic hormone, ADH. ADH is produced by both the supraoptic nucleus and the paraventricular nucleus of the hypothalamus, stored in the posterior pituitary. ADH increases the free water reabsorption by the medullary collecting duct, MCD, of the kidney by causing aquaporin insertion. If ADH is elevated, we get elevated free water reabsorption and dilution of our serum, leading to a serum sodium osmolality decrease. Likewise, our urine becomes more concentrated, meaning urine osmolality and specific gravity increases. If ADH is decreased, we get decreased free water reabsorption and concentration of our serum, leading to a serum sodium and osmolality increase. Likewise, our urine becomes more dilute, meaning urine osmolality and specific gravity decreases. The primary cells in the brain that recognize serum osmolality and contribute to the secretion of vasopressin are the hypothalamic osmoreceptor cells. These are located in the organum vasculosum of the lamina terminalis, OVLT, and the subfornical organ, which detects the changes in the osmolality of the blood. Elevated serum osmolality causes these osmoreceptors to stimulate the nearby supraoptic and paraventricular nuclei. SIADH, syndrome of inappropriate antidiuretic hormone secretion, means too much ADH, vasopressin secretion. Central SIADH follows head trauma, meningitis, brain cancer, and pain, latter on 2CK surgery. Ectopic SIADH, small cell lung cancer secreting ADH. Drug-induced ADH, ultra rare on USMLE, but carbamazepine can do it. Patient will have dilute serum and concentrated urine. Decrease in serum sodium, decrease in serum osmolality, decrease in serum specific gravity. Elevated urinary osmolality, elevated urinary specific gravity. You must know serum sodium is normally 135 to 145 milliequivalents per liter, so in SIADH, it's less than 135. Serum versus urinary osmolalities will be all over the place, and you do not need to memorize these values. They might say that the serum osmolality is 250 and the urinary is 750, and then you'll say, well, I can tell serum is dilute compared to urine, which sounds like SIADH. Specific gravity will be 1.000 to 1.030 on USMLE. Sounds obscure, but it shows up quite a bit, particularly on 2CK questions. It's my observation that values 1.000 to 1.006-ish are dilute, and 1.024 to 1.030 are concentrated. For 9 out of 10 questions, values will be what you expect. As I talk about in detail in my high-yield arrows PDF, only the medullary collecting duct osmolality will change in response to ADH. The USMLE will ask you for the osmolality of the urine at different nephron locations in comparison to serum, and the combination is PCT isotonic, the juxtaglomerular apparatus JGA hypotonic, MCD hypertonic. The PCT is always isotonic no matter what. The JGA, at top of thick ascending limb of loop of Henle, is always hypotonic no matter what. The MCD, what are we defining as MCD? Did we mention that before? I know we mentioned it right now, but like medullary collecting duct. The MCD is clearly hypertonic in SIADH since we're pulling free water out of the urine. So in the context of SIADH, it's clearly hypertonic. But in other cases, though, JGA is always hypotonic, and PCT is always isotonic. Fluid restriction is first answer in diagnosis on 2CK. we want to see how serum/urinary values change in response. Demeclocycline is answer on 2CK offline NBME8 for treatment of SIADH. Demeclocycline is technically a tetracycline antibiotic, but isn't used because it can cause insensitivity to ADH at the kidney, like nephrogenic DI. So we essentially cause a second problem that cancels out the first problem. Or we could say, for example, that any problems are simply when something like a homeostasis is no longer preserved and now things are out of bounds and disorderly, and that a restorative function in one context would actually be disorderly in a different context. Let's say, for example, if you were trying to, I don't know. Let's say, for example, somebody is trying to give you let's say they're trying to add let's say a kidney to your body. And you might say, well, I don't need a kidney. I have two kidneys that function. Yes, exactly. But if you had a sick kidney, or let's say you were born for some reason for only one kidney, maybe you would need a second kidney, right? As an imperfect analogy, right? The reality is that, or let's say, for example, you're very, very, very dehydrated, and so you drink water or you receive some sort of IV infusion for fluids to ensure that you don't have these very, very low hypotensive situation and you're dehydrated. But a person who otherwise has normal body fluids, you don't need to do IV hydration, and you don't need to drink fluids in excess, what would be otherwise considered in excess. It's contextual. What's considered your current situation is going to be distinct, and so to maintain homeostasis will be distinct. And so calling it fixing one problem of a second problem is not really accurate. It's more likely to say that we're trying to do one thing that counteracts the first thing, because the first thing downstream of that causes a problem, and therefore we have to counteract this one direction by going in the opposite direction. It's like, for example, if you drove to the wrong location and now you're 5 miles south of where you're trying to be at, well, then you have to go drive 5 miles north, obviously. You see what I'm saying? Anyways, that's just like a conceptual idea of like what is pathology versus what is, treatment, that kind of thing. Whatever. That was a bit of a detour, but whatever. Conivaptan and tolvaptan are ADH receptor antagonists that can be used for SIADH. Central diabetes insipidus means there's not enough ADH secretion by hypothalamus, or the posterior pituitary is unable to release it properly. Nephrogenic DI, leading to insensitivity to ADH at the kidney, serum ADH elevated. Similar to central SIADH, central DI can be caused by head trauma, meningitis, and cancer. And we're still really talking about DI right now. So let's continue like that. Okay, so DI, nephrogenic DI is caused by lithium, demeclocycline, hypercalcemia, and NSAIDs. There is an MBME question that asks about a patient response to ADH who was on chronic NSAIDs, and the answer is that variable, different response to ADH, and variable urinary osmolality, meaning no change. So no changes in ADH response or urine osmolality. So 2CK question gives you patient with primary hyperparathyroidism and a significantly elevated serum calcium plus nephrogenic DI. Question asks about the cause of the DI. The answer would be hypercalcemia. High calcium can cause renal insensitivity to vasopressin. Serum versus urinary values are the opposite of SIADH. Elevated serum sodium would be greater than 145 milliequivalents over liters, and elevated serum osmolality, elevated serum specific gravity. Decrease in urinary osmolality, decrease in urinary specific gravity. PCT isotonic, JGA hypotonic, MCD hypotonic. The PCT is always isotonic no matter what. The JGA is always hypotonic no matter what. The MCD, that's the medullary collecting duct, is clearly a hypotonic in DI since we're not pulling free water out of the urine. So in this case, it's hypotonic. When we're trying to first diagnose DI, the first thing we do is fluid restriction. Same as with SIADH. We want to see how the serum and such urinary values change first. After we determine that the urine is staying dilute plus the serum is staying concentrated, the next best step is desmopressin, analog of vasopressin. If the urine gets more concentrated, i.e. if the drug works, we know the central DI is the diagnosis and we're merely deficient in ADH. If desmopressin does not work, we know that we have a nephrogenic DI, which means that the body's not reacting to ADH. That's the issue, and nephrogenic. I should point out that even if it is nephrogenic DI, desmopressin might work but only very little, whereas with central DI, administration will significantly increase urinary osmolality robustly. It will be obvious on USMLE, but my point is, don't say, oh, well, desmopressin worked like 5%, so we don't have nephrogenic DI here, because it might have some very, very minor effect. Treatment for central DI is therefore desmopressin. Treatment for nephrogenic DI is NSAID plus a thiazide. Sounds weird, but decrease in sodium reabsorption induced by thiazides in the early DCT promotes compensatory increase in sodium reabsorption in the proximal convoluted tubule, where water follows the sodium and our net loss of fluid is less than without the thiazide. In healthy individuals, however, they will lose more net fluid with the thiazide. The NSAIDs presumably decrease the renal blood flow, which will decrease the GFR and cause a decrease in net fluid loss. There is difficult 2CK NBME question where they say the patient is on lithium plus has an increase in urinary output, and fluid restriction is wrong answer to this question. I say this is hard. I say hard because 9 out of 10 times fluid restriction is the correct answer when solicited. But in this case it isn't. Answer would be an NSAID plus a thiazide diuretic. The implication is that if it's obvious that the patient's diagnosis is already nephrogenic DI, just going to straight to the treatment is acceptable. At least in certain circumstances like this, potentially. Just be aware of the possibility. That might be the answer. Because even in some cases where the answer is likely to be something, oh, I think it's probably this, it still might be the do diagnostic checking, to be fair. So it's kind of hard to discern which one would be the more appropriate. Just try to kind of play, I don't know, I would just say play it by ear maybe, just to kind of see what the situation is. What makes more sense? Is it abundantly clear and that treatment is available? Or is it a little bit more dubious and, you know, it might be good to get and there's no really good treatment option they have for you, like the one they just gave you. If they have a good diagnostic option and it's kind of dubious, I would go for the diagnostic option, and that's probably true most of the time. If they have a good treatment option and no good diagnostic option, which is the water retention thing, and again, it's more obvious, or maybe they even did it, maybe they already did it anyways, right? They already did the diagnostic criteria and already confirmed. You know, just be aware of the context of the question. PP, psychogenic polydipsia, means that the patient is simply drinking too much water. Both the urine and serum will be dilute. Serum versus urinary values are the opposite of SIDH. Decrease in serum sodium leads to a decrease less than 135 milliequivalents over liters. Decrease in serum osmolality. Decrease in serum specific gravity. Decrease in urine osmolality. Decrease in urinary specific gravity. I would say that 3/4 of questions on USMLE are obvious, and will say some psych patient is drinking lots of water to clear themselves from evil spirits, etc. Probably a fourth of questions won't be an obvious psych vignette, but will just show you the lab values where you have to say the urine serum are both dilute, so this is psychogenic polydipsia. First step in diagnosis is fluid restriction in order to see how urinary / serum values change. Acromegaly. Acromegaly is caused by an excess of growth hormone secretion, usually by a tumor, followed by closure of the growth plates, which causes an increased growth hormone secretion prior to the growth plate closure, causes gigantism. So basically, if you are a child, let's say you're 10 years old and you don't have your growth plates closed yet, well then you'll get gigantism because your long bones will just continue growing long. But if your growth plates are closed now, that means the only way that it can grow on the body is like the sort of accretional development in the joints, on the face, on the hands, and stuff like that, where you have more prominent looking features. You almost look, I can't say this for 100%, but you almost look more robust in the physical features a little bit. Not exactly, it might not be the best way to describe it, but it's more of this accretional development rather than the sort of you're not getting taller. You're just kind of like built. The bone's just getting thicker. Is the best way to phrase it. The bone's getting thicker in acromegaly, but when you're young and your bones have not fused yet, have not closed yet, the bone plates, then you actually get taller and you get large in a gigantism kind of way. If that makes sense. As mentioned earlier, growth hormone goes to the liver, which causes it to secrete IGF-1. It is then IGF-1 that induces growth effects at tissues. An NBME question gives easy vignette of acromegaly and then asks what you check. Serum growth hormone is wrong. The answer would be serum IGF-1. Acromegaly causes prognathism, lantern jaw, large ear/nose, arthritis, carpal tunnel syndrome due to the increase in joint and tendon growth, enlargement of hands and feet, hypertension, type 2 diabetes, because growth hormone causes insulin resistance, that's true, and it increases the risk of arrhythmia and cardiomyopathy. Treatment of would be somatostatin analog octreotide. Somatostatin is aka growth hormone inhibiting hormone, GHIH, and shuts off its secretion from the anterior pituitary. It also decreases secretion of insulin and glucagon from the pancreas. Okay, let's just continue. I think we'll go into a little bit more. So this one, by the way, I should have said before maybe. We're on page 349. We'll wrap up in theory on page 375. So we've gone through a few pages so far. I would say this one's not as long as it's not as long as some of the other chapters. I might split it up into two different videos, but we'll have to see. Hashimoto thyroid. I probably will split it up, but so high yield thyroid diagnoses. Hashimoto thyroiditis, autoimmune destruction of the thyroid gland, lymphocytic infiltrate seen on biopsy, asked on MBME, antimicrobial, aka anti-thyroid peroxidase, plus antithyroglobulin antibodies, decrease in T3, decrease in T4, elevated TSH. 131, is that iodine uptake? Yeah, I would imagine so. 131 iodine uptake scan is decreased or patchy, that is to say the gland is not producing hormone. Buzzy findings are weight gain, brittle hair / dry/doughy skin, cold intolerance. The USMLE will often omit these findings because they're too easy. Well, that's fun because if you have a real patient, you'll see those findings, but whatever. We can't give it away. We have to ask you, but we can't make it, clear. High yield additional findings I've seen on BME questions are bradycardia, menstrual irregularity. So by the way, bradycardia 55 to 60 BPM. Menstrual irregularity, dyspnea / depression / apathy, carpal tunnel syndrome due to the glycosaminoglycan deposition, elevated cholesterol, proximal muscle weakness of elevated creatine kinase, hypothyroid myopathy, transaminitis. Sounds weird, but LFTs can be elevated. Associated with the other autoimmune diseases like, for example, type 1 diabetes, pernicious anemia, vitiligo, and immunodeficiencies like IgA deficiency. For USMLE, a high-yield big-picture concept is that autoimmune diseases go together, where if you have one autoimmune disease, there's an elevated risk of other autoimmune diseases. The strict HLA associations aren't important outside of maybe HLA B27. In addition, autoimmune diseases and immunodeficiencies going together, where have a autoimmune disease in general increases the risk of immunodeficiencies and vice versa. So elevated risk of non-Hodgkin lymphomas, that is to say primary CNS lymphoma, and a treatment of levothyroxine or triiodothyronine. Graves' disease. Activating antibody against TSH receptor. This antibody is called the thyroid stimulating immunoglobulin, TSI. Elevated T3, T4, and a decrease in TSH for Graves' disease. So, lymphocytic infiltrate plus hyperplastic thyroid follicles seen on biopsy. A 131 iodine uptake scan shows diffusely elevated uptake. Exophthalmos, aka proptosis, protrusion of the eyes, pretibial myxedema, non-pitting edema and of shins due to the GAG deposition are specific findings in Graves'. The vignette needed not to mention either of these findings, but if the question specifically tells you there's a no exophthalmos, they're saying it's not Graves'. Buzzy findings are tachycardia, heat intolerance, sweating, and palpitations. Myopathy can also occur with increase in CK, but USMLE tends to give you this finding in hypothyroidism. It can cause atrial fibrillation, AFib, in young patients. Normally, AFib is elderly. Thyroid storm is an acute exacerbation of Graves' disease, often precipitated by stress factors such as surgery, trauma, or infection, where thyroid hormone production goes to be significantly elevated, causing dangerous physiologic responses such as hyperthermia, tachycardia, and altered mental status. Thyroid storm can also cause adrenal crisis, for example, acute decrease in the blood pressure due to rapid consumption of cortisol, especially in those with concurrent adrenal insufficiency, taking exogenous steroids. Treatment for the low blood pressure is IV glucocorticoid, that is to say, for example, hydrocortisone or methylprednisolone. Treatment for general Graves is thionamides, propylthiouracil, PTU, and methimazole. PTU and methimazole both inhibit thyroid peroxidases. PTU has an additional MOA of inhibiting 5-deiodinase. Both PTU and methimazole can cause neutropenia, agranulocytosis. Propranolol is used for tachycardia and hyperthyroidism. Beta blockade inhibits 5-deiodinase. Oral prednisone is specifically used for treatment of exophthalmos, not thionamides. Treatment of thyroid storm on USMLE is tetrad of 1. PTU, propylthiouracil, 2. Propranolol, 3. Steroids, and 4. Potassium iodide. Shuts off the thyroid gland due to the Wolff-Chaikoff effect. Wolff-Chaikoff effect is a transient decrease in the thyroid hormone synthesis in the setting of an acute increase in iodide exposure, which prevents excessive thyroid hormone production. Tangentially, if USMLE question gives you a patient exposed to radioactive iodine, for example, working in a laboratory, the treatment is potassium iodide, which saturates the thyroid gland with regular iodide and prevents uptake of the radioiodine, thereby preventing destruction of the gland, because it is dangerous to the gland. In fact, you can actually use radioactive iodine to ablate your thyroid gland if you have hyperthyroidism. So one of the ways you can destroy the thyroid is by using radioactive iodine. It uptakes the iodine and it destroys the cells, damages them. Decurvain thyroiditis, aka subacute granulomatous thyroiditis, or just simply subacute thyroiditis. Mechanism is viral infection followed by a painful/tender thyroid. There is inflammation of the thyroid gland which causes the spacing between the cells to increase slightly, allowing for the release of preformed thyroid hormone into the blood. Therefore, we have a decrease in TSH, an elevation in T3, an elevation in T4, and a decrease in 131 iodine uptake. The gland is not overproducing thyroid hormone. This is why uptake is not increased. Subacute granulomatous thyroiditis can be either a hypo or hyperthyroid. The key details you need to know is that uptake is always decreased if the patient is hyperthyroid. Decurvain's vignettes will almost always be given as hyperthyroidism because USMLE wants to specifically assess that uptake is decreased. Okay. Interesting. If they give you a hypo, of course you will select a decrease for uptake. Decreased uptake applies to all thyroiditis conditions, i.e. Decurvain, drug-induced, and postpartum. Viral infections are often asymptomatic, so most Decurvain's vignettes will not mention the viral infection. Drug-induced thyroid, so that's a good point to be made. So you might have a question where you think, oh, well, clearly there has to be some sort of precipitating illness before you have the autoimmune reaction. The answer is no, you don't, because you might be asymptomatic for it. You might have it, you just won't notice it. And so therefore won't mention it in the question necessarily. Because in real life, they might not even acknowledge it. Drug-induced thyroiditis caused by lithium or amiodarone on USMLE can in theory be hypo, or hyperthyroid. Will usually present on USMLE as painless hypothyroidism in patient being treated for bipolar disorder, lithium, or started on a new antiarrhythmic like amiodarone. Will present with a decrease in 131 iodine uptake where inflammation of the gland can sometimes cause leakage of the thyroid hormone into the blood, but the gland itself is not demonstrating increased production of hormone. Subclinical hypothyroidism. Elevated TSH, but basically the same levels of T3, same levels of T4, but elevated TSH. In subclinical hypothyroidism, the patient will have an asymptomatic, hence subclinical, and have a normal T3 and T4 despite an elevated TSH. Most patients with subclinical do not need to be treated. Don't treat unless the TSH is greater than 10. patient is pregnant, or anti-Hashimoto's antibiotics are positive, or antibodies are positive. That makes more sense. Hashimoto antibodies are positive. Okay. Euthyroid 6 syndrome. So vignette will give patient has so let me read this. Vignette will give patient being weaned from a ventilator or someone who's had recent major trauma or surgery. Normal levels of TSH, normal levels of T4, decreased T3, increased RT3. Etiologies are manifold, but one proposed mechanism is that in times of stress, usually acute, spikes in cortisol and other inflammatory mediators can inhibit peripheral conversion of T4 to T3. This causes T3 to go down. However, for T4, rather than being detectable in excess, it's converted to an inactive form of hormone called reverse T3 or RT3. So RT3 is high. T4 is therefore still in the normal range, as is TSH, presumably because T4 is normal. Call it weird all you want, but USMLE asks this. This is one of the most underrated thyroid diagnoses. It sounds like it because I don't think I've ever heard of this one before. If I have, then I've forgotten about it. As a student, will often have heard of it, but then we're disregarded, thinking it's a minutia and probably won't show up. It's possible that I've heard this before in the past, but I just simply don't have any good recollection of it. So, okay. Toxic adenoma. Autonomously secreting thyroid nodule, aka hot nodule. 131 iodine scan shows uptake into the area of the skin of the single nodule, elevated T3, T4, and a decrease in TSH, not malignant, i.e. no metastatic potential. Toxic multinodular goiter. So for toxic multinodular goiter, autonomously secreting thyroid nodules, i.e. many hot nodules, 131 iodine scan shows multinodular uptake, elevated T3, elevated T4, and a decrease in TSH. It's not malignant, i.e. no metastatic potential. I don't think I've ever seen this as a correct answer in USMLE, but it shows up quite a bit as a distractor. That is to say, for example, from the Dequervain questions. Occurs in elderly. You might get a younger patient with hyperthyroidism due to Dequervains, and you have to eliminate toxic multinodular goiter because, one, the patient is young, and then two, Dequervains is painful/tender, whereas toxic multinodular goiter is not painful. So if you see something like that as an answer, maybe it's Dequervains and not that. So just think about, is it painful or not painful? If it's painful, then it's not TMG. It's going to be Dequervains probably. Right. Is it patient young? Well, it's probably not TMG because that means it still might more likely be Dequervain. So just bear that in mind. Some things exist on the exam not because they have questions dedicated them in it of themselves, but because they are simply distractors as potential answers you can choose from, which are almost always invariably wrong. Again, whatever exam you get probably was not going to be some sort of carbon copy of something that happened in the past, but it probably will have a lot of overlap, you could say, in terms of the content you might see and the kinds of strategies you could use to do well on the exam. Factitious thyrotoxicosis, aka surreptitious thyrotoxicosis. USMLE need not to mention the patient is a pharmacist, implying the access to the hormone. Question will give you a hyperthyroid patient with a small, non-palpable thyroid gland, atrophic due to the suppressed TSH. As mentioned earlier, T4 is converted to T3, but T3 is not converted to T4. So if thyroxine is administered, we will have elevated T3 and T4, but decreased TSH. If triiodothyronine is administered, however, we will have an elevated T3, a significantly decreased T4, and a decreased T4 and a decreased TSH. And that makes sense because T4 is converted to T3, not the other way around though. So that makes sense. And I think I'm taking a short break here. Okay, I am back. Let's continue with thyroid nodule evaluation. When evaluating for thyroid cancer, the first step is palpation of thyroid gland before check serum TSH. Then is an NBME question for 2CK where both are listed and palpation is correct. That is to say, do a history and exam before jumping into tests. Once a nodule is palpated, then serum TSH is the next step. If the patient with a nodule has a normal or high TSH, that is to say, is a euthyroid or hypothyroid, do ultrasound before fine needle aspiration, FNA. This is assessed on the new 2CK 312-120, where the ultrasound is correct over the FNA for evaluation of thyroid nodule. It has long been pushed in resources that ultrasound is always wrong, but this is on free 120. 2CK internal medicine CMS question gives euthyroid patients with nodule where the FNA is the answer. Okay. But the ultrasound is not listed. So my conclusion based on the NBME free 120 content, not my opinion, is that for euthyroid or hypothyroid patient with thyroid nodule, ultrasound is correct over the FNA. Can I just get a free needle aspiration? Ultrasound is correct over the free needle aspiration if both are listed. If ultrasound is not listed, then choose the free needle aspiration. If the patient has a low TSH, that is to say has hyperthyroid, do a 131I uptake scan, not ultrasound. Since carcinomas are non-secretory of the thyroid hormone, if our patient is hyperthyroid, we're not concerned about carcinoma, which is why we don't go to the ultrasound, then the fine needle aspiration route. We just do the uptake to better see that if the patient's etiology for hyperthyroidism is Graves' diffuse, toxic adenoma, single nodular uptake, or toxic multinodular goiter, multifocal nodular uptake. A caveat about the above algorithm for nodule evaluation is that if a patient has hyperthyroidism, that is to say low TSH, and does not have a nodule, then you will choose ultrasound over an uptake scan. I know this sounds annoying, but USMLE assesses this. There is a new NBME question where they give you low TSH in a young patient with no mention of nodule, and the answer is ultrasound over uptake scan. But in the questions where TSH is low and the patient has a nodule, the answer is uptake scan first over ultrasound. If you want a high score, then you know the difference. Okay. So here's a little thing here. It shows thyroid nodule. If the TSH is low, go for radioiodine uptake scan. If the thyroid nodule, if the TSH is normal or high, you go for ultrasound first. And if that's not listed, you're going to go for the fine needle aspiration. If you have no nodule, then you just do an abnormal TSH, which in case you go to ultrasound. Okay? So TSH is screening for everything not pregnant. T3 and T4 can be ordered after the TSH, but question often omits this. Screening in pregnancy is free T4. Most diagnostic/accurate for everyone is free T4. Algorithms that are more detailed as far as size of nodule, etc., are basically nonsense for USMLE. What about thyroid and pregnancy? For pregnancy and USMLE, choose the combination of no change in TSH, no change free T4, elevated total T4 for women who have no thyroid problems. Estrogen causes an elevated thyroid binding globulin (TBG) production by the liver. TBG is the protein carrier molecule for the thyroid hormone in the blood. An NBME question asks for which hormone causes the elevated TBG in pregnancy. This gives you an answer of estrogen, not progesterone. Free T4 is the physiologically active form of the thyroid hormone. T4 protein bound to the TBG 99% has minimal effect. Free T4 plus TBG bound T4 is total T4. TBG will mop up free T4, causing the free T4 to transiently decrease and TSH to rise, less negative feedback. This rise in TSH will stimulate more production of T4 by the thyroid gland, making the total T4 go up. The absolute amount of free T4 will increase back to normal, thereby suppressing TSH back to normal. But the total amount of T4 is now increased. That is to say, free T4 is normal again, but TBG-bound T4 is higher. T3 is normal because the free T4 is normal. Free T4 is peripherally converted to T3. I've never seen anything about free T3 on MBME material, and I wouldn't worry about it. A student might say, wait, but why are you giving the above bold arrows if you just gave me all sorts of transient changes in the arrows based on TBG? It's because the bold arrows are what the USMLE wants. Pregnant women who are euthyroid will have a normal T4, an increased total T4, and their TSH will be normal. The change due to the TBG rising are likely synchronous and slow enough that the patient's TSH and free T4 stay within reference ranges. Postpartum silent thyroiditis can result in either hypo or hyperthyroidism following the parturition. These arrows are unrelated to the aforementioned ones. The highest yield point you need to know is that 131 iodine uptake into the thyroid is low, even if the patient is hyperthyroid. This is the same for Dequervain and drug-induced thyroiditis, where the uptake is always low. This is because with thyroiditis conditions, there is merely increased spacing between the cells of the thyroid gland due to the inflammation, allowing for thyroid hormone to leak out into the blood. The gland itself is not excessively producing thyroid hormone. Then we have a negative feedback causing the low TSH, and in turn less stimulation of the thyroid gland, which is why uptake is low. If USMLE asks you about the levothyroxine dosing during pregnancy, the answer is increase dose by 50%. Avoid methimazole in the first trimester, teratogenic. Propylthiouracil is the answer for thyroid storm during pregnancy, even though longer-term use in second and third trimesters isn't considered ideal because of hepatic toxic risk. Thyroid in pediatrics. Thyroglossal duct cyst, benign, painless midline neck mass in school-age kid that arises from a persistent thyroglossal duct, that is to say, for example, an embryologic remnant of the thyroid gland's descent from the base of the tongue to its final position in the neck. 2/3 of the questions will give a painless midline neck lump that moves upward with swallowing or protrusion of the tongue due to its attachment to the thyroid bone and or the base of the tongue. 1/3 of questions won't mention the buzzy upward movement with swallowing or protrusion of the tongue. Instead, it will just say a kid has a painless midline neck mass just inferior to the thyroid bone that demonstrates 99 TC uptake. That's just I don't know what the isotope is for TC. I'm off the group on that one. I don't know. Let's see. The element for TC is technetium, I would say. Created artificially in 1937 by Carlo Perrier and Emilio Segre. That's interesting. So does it exist in nature? Sorry for the detour, I just want to know. It was the first predominantly artificial element to be produced. Okay. So that's technetium. Where were we? 99 technetium uptake. Lingual thyroid. Lingual thyroid, obscure cause of hypothyroidism that shows up on an offline MBME, refers to the presence of ectopic thyroid tissue located at the base of the tongue due to the failure of the thyroid gland to descend from the foramen cecum. This ectopic tissue may be the only functioning thyroid tissue in the body, resulting in hypothyroidism. The USMLE will always say a kid has hypothyroidism plus a midline neck lump located high in the neck. They say nothing about protrusion of the tongue or uptake into the mass. Can sometimes cause dysphagia, trouble swallowing, dysphonia, voice changes, or dyspnea, difficulty breathing. What about cretinism? Now, you don't want to be calling people cretins here and there. That's not a wise decision. But there is a disease called cretinism, aka congenital hypothyroidism. Most common cause are iodine deficiencies in the mother during pregnancy, worldwide, and fetal thyroid dysgenesis, Western countries. Leads to mental retardation, poor myelin and sheath development, impaired bone growth, hypotonia, macroglossia, and protuberant abdomen due to the umbilical hernia. Can be confused with kwashiorkor disease, which is protein calorie malnutrition causing ascites. Screen, which is also another issue of sort of like this, it's like a failure to thrive disease for a different reason. Screen for at birth using the heel prick test to prevent exacerbation. What about TBG deficiency? The USMLE does not expect you to know about some obscure condition called thyroid binding globulin deficiency. The reasons they ask about this is because the role of TBG on thyroid hormones in pregnancy is exceedingly high yield. So, if you know the reasoning for mechanism behind the latter, then you can easily infer about what would be seen in TBG deficiency. That is to say, the inverse. So you have normal TSH, normal T3, normal free T4, but a decreased total T4. In pregnancy, since the TBG is high, this ultimately results in a high total T4 despite a normal T4. So, normal free T4. So the student can easily infer, well, if our TBG merely is low rather than high, then total T4 must be low, while free T4 is about the same. Sort of like pregnancy, but just the opposite direction. Okay, so let us continue. Parathyroid points. Parathyroid hormone, or PTH, functions to increase the serum calcium and decrease the serum phosphate. Parathyroid hormone, PTH, functions to increase serum calcium in three main ways. 1. Pulls calcium out of the bone and puts it into the blood. PTH binds to the osteoblast, which will then express rank L on their surface, which will bind to the rank receptor on the surface of osteoclasts. Osteoclasts then reabsorb or break down the bone. The calcium enters the blood, increasing the serum calcium. 2. It increases renal absorption of calcium. PTH causes calcium reabsorption at the late distal convoluted tubule of the kidney by increasing the expression of an apical calcium channel. 3. Upregulates 1-alpha hydroxylase. PTH upregulates a 1-alpha hydroxylase in proximal convoluted tubule of the kidney, which converts inactive 25-hydroxy vitamin D3 calcidiol into the active 125-hydroxide D3 calcitriol. 125-hydroxy D3 then goes into a small bowel where it increases the absorption of both calcium and phosphate. PTH decreases serum phosphate by inhibiting its reabsorption in the PCT of the kidney. PTH causes the downregulation of apical PCT phosphate transporters. If PTH is low, we don't get downregulation of these transporters. Too much phosphate is reabsorbed and serum phosphate goes up. Let me take a brief break again. Okay, we are back. So let us go now down to vitamin D pathologies for internal medicine. Rickets/osteomalacia. Rickets, vitamin D deficiency in children. Osteomalacia, vitamin D deficiency in adults. Calcium and phosphate are both low because of vitamin D is needed for intestinal absorption of both. PTH goes up, the parathyroid hormone goes up because calcium is low, decreased negative feedback. It should be noted that in vitamin D deficiency caused by renal failure, phosphate is high, not low, because of the effect of renal failure on phosphate levels wins over the mere vitamin D deficiency. In renal failure, the kidneys cannot downregulate the PCT, phosphate reabsorption channels, thereby increasing the absorption. Renal failure always has high phosphate, even though vitamin D3 activation is low. Renal failure plus low vitamin D means you're going to have a low serum calcium, an elevated serum phosphate, and an elevated serum PTH. No renal failure plus low vitamin D, i.e. rickets or osteomalacia, will give you a low serum calcium, a low serum phosphate, and an elevated PTH. What about renal failure? Inability for PTH to activate the 1-alpha hydroxylase in the PCT of the kidney. Decrease in 125D3 synthesis, but a 25D3 is normal. 25D3 doesn't build up physiologically if there is an extra 25D3 because it is not being converted to 125D3. Then it gets shunted sideways to another inactive form called 2425D3 as on MBME. Osteomalacia, resulting from renal failure, is called renal osteodystrophy. What about hyperparathyroidism conditions? Primary, elevated calcium, decreased phosphate, elevated PTH. Primary hyperparathyroidism is usually due to a PTH secreting adenoma, but can also be due to a diffuse foregland hyperplasia. Can be part of the MEN1 or 2A discussed later. Elevated urinary calcium plus an elevated serum calcium plus an elevated urinary cyclic AMP. Some students will immediately think there's an erratum with the above arrows. There's not. Relax. In primary hyperparathyroidism, PTH will be high. PTH functions to reabsorb calcium in the late distal convoluted tubule of the kidney. So in theory, you'd think urinary calcium would be low, not high. Sounds logical. However, even though there's more calcium is indeed reabsorbed in the late distal convoluted tubule, since serum calcium is high in primary hyperparathyroidism, more calcium is filtered through the glomerulus to begin with. So even though more is reabsorbed distally, the urinary calcium is still high because we had more to start with. PTH causes increased urinary cyclic AMP. This is a weird variable that you should be aware of. PTH acts through the G-alpha S-G proteins, where the adenylyl cyclase activity and in turn cyclic AMP are increased. Secondary. So this is going to be secondary hyperparathyroidism. Decrease in calcium, elevated phosphate, elevated PTH, and decrease in 125D3. Secondary hyperparathyroidism is due to renal failure. There is two reasons why calcium would be low. One, the kidneys cannot reabsorb it in the late distal convoluted tubule like it's supposed to. Two, the kidney cannot synthesize activated 125D3 in the proximal convoluted tubule like it's supposed to. Since 125D3 reabsorbs calcium in the small bowel, and 125D3 levels are lower, serum calcium will also be lower. This lower serum calcium will cause the PTH to go up, decrease negative feedback at the calcium-sensing receptors on the parathyroid glands. Since the etiology for the increased parathyroid hormone secretion is not the parathyroid glands themselves, we can call this a secondary hyperparathyroidism. And the etiology is due to the parathyroid glands themselves, that is to say the adenoma or diffuse hyperplasia, we call that primary hyperparathyroidism. The calcium and phosphate arrows for secondary hyperparathyroidism are the opposite of primary hyperparathyroidism. Phosphate is high in renal failure, despite the high PTH, because the kidney is not able to downregulate the PCT phosphate transporter, so there is too much phosphate reabsorption, which is interesting. Tertiary hyperparathyroidism. elevated calcium, elevated phosphate, elevated PTH. So I just want to make this clear for you. Let's go back to primary. Primary hyperparathyroidism, you have high calcium, low phosphate, high PTH. For secondary, you have low calcium, elevated phosphate, elevated PTH, low 125D3. So basically, the calcium and phosphate levels are reversed, and PTH remains high, of course. But 125D3 is also low. Why is that? Because we're talking about something that's downstream of what? Renal failure, okay? Tertiary, calcium is high and phosphate is high at the same time, which is not true for either of the previous types, where they have one is low and the other one's high. But also PTH is also high, which is again expected because it's called hyperparathyroidism. So tertiary. In order to understand tertiary hyperparathyroidism, let's first review secondary hyperparathyroidism. Patients with renal failure will initially develop secondary hyperparathyroidism where the calcium is low, phosphate is high, and PTH is high. Calcium is low due to the failure of the reabsorption of the late distal convoluted tubule of the kidney and because of decreased synthesis of activated vitamin D3 leading to a decreased small bowel reabsorption or absorption. Phosphate is high due to the failure to downregulate the PCT, proximal convoluted tubule reabsorption pumps, that is to say, for more pumps to reabsorb phosphate. PTH is high because calcium is low, less negative feedback. Tertiary hyperparathyroidism results from hyperplasia of the parathyroid glands in the patients with long-standing secondary hyperparathyroidism. That's interesting. So it's from the secondary type, such that even if the renal failure is brought under control and serum calcium is brought back into normal range, PTH continues being autonomously secreted at higher basal levels than prior to the renal disease, effectively resetting the body's set point for calcium homeostasis. That's interesting. That's very, very, very interesting. This causes a rise in serum calcium in a patient with renal failure. This should immediately raise a red flag for tertiary hyperparathyroidism, since renal failure patients will almost always have low, not high, calcium. Even though the parathyroid glands will be hyper-secreting PTH, this is not primary hyperparathyroidism, since the etiology for this high PTH was not idiopathic adenoma or hyperplasia. Phosphate is high, not low. Because the patient has renal failure, phosphate is always high in renal failure. Even though PTH is high, remember that the kidney cannot downregulate the PCT, proximal convoluted tubule, reabsorption pumps the way they're supposed to. So where are we now? Okay, yeah, I'll continue a bit more. I feel like I do have, obviously I don't want to go, it doesn't feel all that fun and well to go for, I've gone through maybe 8-ish pages as of yet. It's probably not going to be all fun and games to do another 20 pages or so. However, I feel like I could probably do it if I wanted to kind of pace myself, in one go. So let's see how long this section is. Okay, let's go for that for a bit. Hypoparathyroidism condition. So hypoparathyroidism now. DeGeorge syndrome. Low calcium, elevated phosphate, low PTH, low T cell levels, and basically normal B cell levels. Mechanism is most frequently 22q11 deletion, resulting in agenesis of the third and fourth pharyngeal pouches. The third pouch becomes the thymus plus 2 inferior parathyroids. The fourth pouch becomes these 2 superior parathyroids. Tetralogy of Fallot and truncus arteriosus are common heart defects. Agenesis of the parathyroid glands leads to a primary hyperparathyroidism, causing low calcium plus high phosphate. DeGeorge is characterized by a T cell deficiency. Recurrent viral, fungal, and protozoal infections are characteristic. Absent thymic shadow means a T cell deficiency, which means DeGeorge. Scanty lymph nodes /tonsils equals B cell deficiency. Bruton 8 gamma globulinemia. If a question says a kid has both absent thymic shadow and scanty lymph nodes /tonsils, that means the answer should be SCID. Post-thyroidectomy, low calcium, high phosphate, low PTH. So in this case, thyroidectomy can result in removal of or damage to the parathyroid glands, resulting in decreased PTH secretion and in turn hypocalcemia. Phosphate goes up because there is an increased renal reabsorption. PTH normally downregulates the apical PCT phosphate transporters, thereby promoting excretion. Twitching of the masseter with stimulation is called the Schwostek sign. That's Chvostek, or presumably it's pronounced Schwostek. Hypocalcemia. Hypocalcemia causes the up findings, i.e. muscle tetany and hyperreflexia. Trousseau sign of the hypocalcemia is carpopedal spasm with blood pressure cuff inflation. That is to say, twitching of the hand and wrist. The USMLE can give you either a Schwostek or Trousseau sign when the calcium is low. Hypercalcemia, in contrast, causes the down findings, that is to say, muscle flaccidity and hyporeflexia. Do not confuse Trousseau sign with hypocalcemia with Trousseau and or Troisier signs of malignancy. Troisier sign of malignancy is a palpable left supraclavicular lymph node, sometimes seen in visceral malignancy, that is aka Virchow node. Trousseau sign of malignancy is migratory thrombophlebitis, classically seen in head of pancreas adenocarcinoma, but can be other adenocarcinomas such as bronchogenic. So a lot of names for a lot of different people for different things. Just be aware of which one is which, and what does that indicate. Hypomagnesemia. Hypomagnesemia, decrease in calcium, elevated phosphate, decrease in PTH, decreased magnesium. So again, low calcium, high phosphate, low PTH, low magnesium. Alcoholics susceptible to hypomagnesemia as a result of dietary deficiency. Alcohol is 7 kilocalories per gram, so they fill up on alcohol. Low magnesium can cause hypocalcemia and hypokalemia, non-responsive to the supplementation. That is to say, if you give calcium or potassium for low serum levels, but the serum levels do not appreciably rise. Basal levels of magnesium are required for proper functioning of the parathyroid gland, so low magnesium can cause low PTH secretion. Patients with hypomagnesemia may indeed have completely normal serum levels for calcium, phosphate, and PTH, but if we are forced to choose arrows, we should choose calcium, phosphate, PTH combo that reflects low PTH secretion. The next step will often just be, say an alcoholic has low calcium or potassium, non-responsive to supplementation. And then the next best step in the management is the serum magnesium levels. This isn't hard at all, but some students will be like, oh, wow. Okay. Let me take a brief break here. I mean a brief break, I don't know, maybe a handful of minutes. But I would, just if you're watching this in recording, just skip forward to the point where I'm start talking again, okay? Okay, I am back from my break. I was taking a little cat nap or deer nap, I guess. I don't know what you would say. Hopefully, it wasn't too crazy, especially if you're obviously listening to a recording and are wise enough to just simply move the video to when I'm speaking again. So, hopefully, you did that and did not waste your time. Otherwise, let us proceed forth. We are on page 156. We want to wrap up on page 375, so we have about 20 pages left in theory. You know what? I'm going to cut this up in two. So I'll try to wrap up here in the next few pages, and then maybe just cut it out, cut in again maybe later today, hopefully today. Other calcium derangement conditions. Paraneoplastic parathyroid hormone RP, which is like a related peptide or something like a related protein. Anyway, paraneoplastic PTHRP. Squamous cell carcinoma of the lung and renal cell carcinoma of both secrete parathyroid hormone related peptide. Related peptide. This is not the same as endogenous PTH. Not the same thing. USMLE questions for renal cell carcinoma and squamous cell of the lung will have elevated serum calcium, low serum phosphate, and low PTH. PTHRP exerts very similar physiologic effects as PTH, causing high serum calcium and low phosphate. PTH secretion by the parathyroid glands will be suppressed in the setting due to a high serum calcium. NBME will give you a lung cancer plus a high serum calcium plus a low serum PTH, with the answer being squamous cell carcinoma of the lung. The low PTH will throw some people off, but this is not weird. PTH is not the same thing as PTH-related peptide, which will be an up arrow. So it's confusing, but the thing is they're considered different things, but they have similar effects. And so we'll say low PTH, but, you know, you have a high PTH-related peptide. Metastases. Elevated serum calcium, low PTH. Once metastases seed at bony location, cytokine activity causes lysis of the bone and releases of calcium into the blood. Hypercalcemia is common in the setting of metastatic malignancies. PTH is suppressed due to the high calcium. Familial hypocalciuric hypercalcemia. Elevated serum calcium, low urinary calcium, low parathyroid of calcium sensing receptor sensitivity, low renal calcium sensing receptor sensitivity. As the name of the condition implies, for familial hypocalciuric hypercalcemia, FHH, serum calcium will be high and urinary calcium will be low. The condition is caused by slightly decreased, not absent, sensitivity of the calcium-sensing receptors at both the parathyroid glands and kidneys, resulting in a slightly higher set point for calcium levels in the blood that may be variable depending on this patient. Most patients are asymptomatic, and PTH is often higher end of normal, or slightly elevated. Patients do not experience signs of bone reabsorption, sometimes seen in patients with primary hyperparathyroidism. In primary hyperparathyroidism, despite increased distal renal reabsorption of the calcium, urinary calcium is still high because serum calcium is high. So more calcium will be filtered through the glomerulus. In other words, if the urine starts off with more calcium, the amount of urinated out is still higher despite increased reabsorption. The calcium-sensing receptors in the renal PCT and loop of Henle function normally and can sense the high calcium, thereby decreasing the paracellular reabsorption unrelated to the PTH's effect in the DCT. This allows for greater calciuresis, urination of calcium. In familial hypocalciuric hypercalcemia, calcium-sensing receptors in the renal tubules unrelated to PTH have decreased sensitivity. Therefore, the tubules interpret urinary calcium to be low and will increase reabsorption in the PCT and loop of Henle to compensate, thereby decreasing calciuresis, less urinary calcium. In other words, in FHH, the kidney thinks, gosh, we must have low serum calcium since I can't sense it, so I am going to reabsorb more so we can retain our calcium. Okay. Pseudohypoparathyroidism. Low serum calcium, elevated serum phosphate, but a decrease in urinary cyclic AMP. If the USMLE asks what change will occur with exogenous PTH administration, choose basically normal serum calcium, normal serum phosphate, normal urinary cyclic AMP. Pseudohypoparathyroidism is caused by a defective PTH receptor and therefore insensitivity to PTH. So it's sort of similar to the difference between nephrogenic DI and primary like neural DI. Like when we talk about DI, there's a nephrogenic type of DI, and it's not an issue of not having ADH around. It's that it doesn't react to the ADH. It's not sensitive to ADH. That's nephrogenic DI. So in this case of pseudo-hypo-PTH, we have PTH. It just doesn't. It's not sensitive to it. It doesn't react to it the way it should. Or sorry, by the way, DI, central DI. They call it central DI versus nephrogenic DI. I just remember the correct terminology for okay. So this is kind of like the nephrogenic form of parathyroid whatever issues is because it doesn't react to it correctly. So there are different types of therefore insensitivity to PTH. There are different types of pseudo-hypoparathyroidism. The USMLE will give you type 1, which presents with what is referred to as an Albright hereditary osteodystrophy phenotype. That is to say, shortened fourth and fifth metacarpals, round face, and bony abnormalities. Osteoma cutis, nodule of subcutaneous ossification, can be seen on retired MBME question. In pseudo-hypoparathyroidism type 1, there is no response to exogenous PTH, so we will not see any changes in serum calcium, serum phosphate, or urinary cyclic AMP. Normally, exogenous PTH would cause an increase in serum calcium, a decrease in serum phosphate, and an increase in urinary cyclic AMP. Patients with pseudo-hypoparathyroidism will have low serum calcium, high serum phosphate, high serum PTH levels. That is, the calcium and phosphate levels appear as though the patient has normal PTH, when in reality there is just insensitivity to it. PTH goes up due to the decreased negative feedback of the calcium-sensing receptors at the parathyroid glands since serum calcium is low. Milk alkali syndrome. Diagnosis of exclusion on USMLE, meaning we eliminate to get there. Textbook scenario is hypercalcemia and metabolic alkalosis, high bicarb, in someone taking too many calcium carbonate antacid tablets for GERD or dyspepsia, indigestion/stomach upset. This can lead to urolithiasis. What the USMLE vignette will do, however, is not to mention the patient's history, but will simply give you a kidney stone plus hypercalcemia plus bicarb that is elevated or toward the upper limit of normal. Then you eliminate to get there. Where you say, even though they don't mention the textbook presentation, no other answers explain the high calcium plus high bicarb. Normal bicarb, let's continue with milk alkali syndrome. Normal bicarb is a 22 to 28 milliequivalent per liter, but an MBME question for milk alkali syndrome gives a bicarb of 27, this throws students off. Acid-base disorders can occasionally have bicarb in normal range, albeit in the direction you expect. Okay. Now we're talking about RAS, adrenal hormone basics. So RAS, renin, angiotensin, aldosterone system. A decrease in renal perfusion stimulates the renin secretion from the juxtaglomerular cells, JGC, of the PCT, the proximal convoluted tubule of the kidney. The juxtaglomerular cells are modified smooth muscle cells that sense decrease in perfusion. The liver produces a protein called the angiotensinogen that is cleaved by renin in plasma into angiotensin 1. Angiotensin 1 goes to the lungs, where angiotensin converting enzyme ACE cleaves angiotensin 1 into angiotensin 2, AT2. Angiotensin 2 has multiple roles, but one of them is to go to the zona glomerulosa of the adrenal cortex, most superficial hormone-producing layer, to upregulate the aldosterone synthase, thereby increasing aldosterone. In other words, decrease in renal perfusion leads to an increase in angiotensin 2 plus aldosterone. If the patient's aldosterone level is high, we look at renin, that is to say, elevated or decreased, to help us ascertain the cause of the increased aldosterone. If renin and aldosterone are both elevated, we know the cause is a decrease in renal perfusion. We call this renal vascular hypertension, where we have either a renal artery stenosis, RAS, caused by atherosclerosis, older patient with CVD risk factors, or a fibromuscular dysplasia, FMD, vascular smooth muscle proliferation disorder in young women. Reninoma is possible but non-existent on USMLE. if aldosterone is elevated but renin is decreased, then we know the cause is of a aldosterone is the primary adrenal, which means that the Conn syndrome, aldosterone secreting tumor, or zona glomerulosa hyperplasia secreting aldosterone might be the cause. The elevated aldosterone causes the elevated plasma volume, which causes an elevated renal flow, thereby decreasing renin through the negative feedback mechanism. So in short, elevated aldosterone and elevated renin means renal vascular hypertension, either because of RAS or FMD. Again, that would be renal artery stenosis or fibromuscular dysplasia. Elevated aldosterone, but a decreased renin means primary adrenal, which means either Conn syndrome or hyperplasia of the zona glomerulosa, which is where it's going to be secreting the aldosterone. So let's talk a little bit more about aldosterone. Produced in the zona glomerulosa of the adrenal cortex, causes an elevated plasma sodium, decrease in potassium, and an elevated bicarb, and an elevated pH. In other words, all the arrows go the same direction as the aldosterone except for potassium. Aldosterone goes to the basolateral membrane side of the blood of the cortical collecting duct in the kidneys to increase the sodium-potassium ATPase pumps. For every 1 ATP utilized, we get 2 potassium secreted from the blood into the tubular cell, which ultimately leaves the body, and 3 sodium are reabsorbed from the tubular cell into the body. When sodium is pulled out of the tubular cell into the blood, this favors a high-low gradient from the urine into the cell of sodium, causing ENaC, a sodium channel on the apical membrane, to indirectly increase in activity, which pulls the sodium out of the urine. In addition, aldosterone upregulates an hydrogen ATPase on the apical membrane side of the urine of the cortical collecting duct, causing an increase in serum bicarb, that is to say, a decrease in plasma hydrogen due to mop up the bicarb, so bicarb will increase. The main purpose of aldosterone is to regulate the fluid status in the body. Water follows the sodium, so the strong sodium reabsorptive effect functions to retain water. The interesting point to note is that ADH vasopressin elevates free water reabsorption without pulling sodium in as well. This effect is more to regulate tonicity of the blood, that is to say, whether plasma sodium is elevated or decreased, by diluting out serum sodium. Vasopressin still has some effect on the volume status, but aldosterone's effect is more robust. What about angiotensin II? In addition to an increase in increased upregulation of aldosterone synthase in the zona glomerulosa of the adrenal cortex, there's 3 other very important roles for USMLE, for angiotensin II. 1, constricts the efferent arterioles leaving the kidney. This causes an elevated hydrostatic pressure backing at the glomerulus, which maintains the GFR in the setting of a decreased renal perfusion. This means that the FF increases. The increased FF, what does that mean in this context? Does it mean fraction or something like that? Sorry, let me check this for a moment. Increased FF GFR. The increased filtration fraction. Okay. So where were we? Okay, so angiotensin II is going to constrict the efferent arteriole leaving the kidney. This causes an increase in hydrostatic pressure back up at the glomerulus, which maintains GFR in the setting of a decreased renal perfusion. This means that the increase in filtration fraction, since the latter is GFR/renal perfusion. It makes sense that at the angiotensin II constricts the efferent arterioles, because when renal perfusion is decreased, GFR will decrease unless we get a squeezing of the hose backup effect leaving the kidney, which functions to maintain the same glomerular filtration in spite of that decrease in the renal blood flow. 2, constricts peripheral arterioles, helps maintain the basal blood pressure. Main reason this function of the the angiotensin II is high yield for USMLE is because they want you to know that the ACE inhibitors, that is, say, for example, lisinopril, or angiotensin II receptor blockers like valsartan or candesartan, decrease the afterload on the heart by relieving the constrictive effects of angiotensin II on peripheral arterioles. This promotes the increase in ejection fraction since there is now less force for the heart to pump against. This effect had helping to increase the ejection fraction in addition to their ability to decrease cardiac remodeling. This is why ACE inhibitors and the ACE receptor blockers are first-line medications in heart failure. 3. This is the third thing that angiotensin 2 does, which is promotes sodium reabsorption in the proximal convoluted tubule of the kidney. It contributes to fluid retention in the setting of a decreased renal perfusion without the need of aldosterone to act distally. For example, in pre-renal azotemia, iron sodium is decreased due to the increase in reabsorption of the sodium proximally by angiotensin 2. If you're confused by this, I discuss all of this stuff in detail in my high-yield renal PDF. Cortisol produced in the zona fasciculata of the adrenal cortex. Two most important roles for USMLE. 1. Maintains the basal blood pressure for the elevated alpha-1 receptor expression on peripheral arterioles. Norepinephrine and epinephrine, catecholamines produced in adrenal medulla, then bind to the alpha-1 receptors causing an arteriolar constriction and blood pressure increase. 2. Maintains nasal blood glucose levels by increasing the insulin resistance at peripheral tissues, physiologic/healthy if the cortisol levels are normal, and an elevated gluconeogenesis. 3. For reproduction/OBGYN, it also accelerates the fetal lung maturity by increasing the surfactant production by the lamellar bodies within the type 2 pneumocytes. ACTH causes cortisol secretion by the zona fasciculata of the adrenal cortex. Cortisol will then induce a negative feedback at the hypothalamus and the anterior pituitary to decrease the CRH and ACT, respectively. If cortisol decreases, well, then CRH and ACTH go to be elevated due to the lack of negative feedback. The precursor to ACTH is pro-opiomelanocortin, POMC, which is cleaved into the ACTH as well as the alpha-MSH, melanocyte-stimulating hormone. Decrease in cortisol causing an elevated CRH leads to an increase in POMC, which leads to an increase in ACTH plus an increase in alpha-MSH, which is why the hyperpigmentation is seen in Addison's disease. Sure. Because it's when it cleaves itself, it has two different molecules which are doing two different things at the same time. And so if you have this processing, Addison's disease will have increased pigmentation. Okay, so we're technically on 359. We didn't finish 359 yet. But, we started off on I like to say 347 if I'm not mistaken. We want to go to 375, and we're getting to 360 soon. So I might just call this the end of this video here, and I would probably do another video today, and if not that, then tomorrow. Anyways, hopefully this video was useful to you. Have a great rest of your day. Thank you, and goodbye.